in the field currently stands. Okay. So the treatment gap for people with mental disorders exceeded 50% in all countries of the world in 2010. And so one of the things that we often say in global mental health is it's true that all countries are a developing country when it comes to mental health. In the United States, we have 50% of US counties where we do not have a practicing mental health professional. So we have huge workforce shortages, inequity in access to services here in the United States. And there's similar patterns, similar challenges in low resource settings like the work we do in Mozambique. In countries like Mozambique, the treatment gaps often exceed 90%. So of all people who need care for mental health conditions, only 10% or less are receiving care. And so these are major gaps occurring in care cascade performance. But it's not just an issue of resources, because even in the United States, where we spend more than $10,000 per capita on healthcare, 56% of adults with mental illness do not receive treatment, and almost 80% of severely depressed youth receive no or inadequate treatment. There's also an issue that there's a very large mental health burden. So in countries like Mozambique, historically, people have neglected considering mental health, considering global mental health in countries like Mozambique. And when you look at funding priorities, when you look at money spent for global health projects, you'll see that the majority has historically focused on infectious diseases, malaria, HIV, maternal and child health, diarrheal diseases, these traditional kind of infectious diseases. But the Institute for Health Metrics and Evaluation's data suggests that for people in middle age, depressive disorders are the second leading cause of years lived with disability. So one of the issues is historically we were identifying funding priorities based on what's killing people, but we weren't considering what's leading people to have suboptimal health or disability, years lived with disability, years lived in suboptimal health. And when we consider that, years lived with disability for those in middle age, in Mozambique, 5 of the top 15 causes of years lived with disability are mental, neurological, or substance use disorders, depressive disorders, anxiety disorders, alcohol use disorders, epilepsy, bipolar disorder, etc. So these are hugely disabling conditions. And even in a country like Mozambique, which has a high burden of infectious diseases, they still rise to the top, even in that context, as being highly disabling conditions and having a large burden. But along with this large burden, we have this huge burden, but we have a huge lack of trained human resources. There's about 30 million people living in Mozambique. There's somewhere between 18, now maybe 25 Mozambican psychiatrists. So I gave a talk with a Mozambican psychiatry collaborator, Vasco Kumbe, a few years back, and it was called like one doctor for each 2 million people, because he is a psychiatrist working in a province in Mozambique where they're serving 2-3 million people, and there are a few psychiatrists, maybe 1 to 2. Mozambique has been a leader in the concept of task sharing and task shifting, so training lower level providers to try to help more rapidly address this large mental health burden through their program of technicians of psychiatry, people who are trained in about 2 years to specifically focus on mental health conditions. We don't have a similar program in the United States, although I guess something like a psychiatric nurse would be similar, but a psychiatric nurse is more generalized. So these people are trained specifically to address mental health. But even with 300, 350 potentially now technicians of psychiatry, we have one of those trained individuals per 100,000 people for this massive mental health burden. So what can we do to address this burden, to address this issue in the near term with these types of challenges? So historically, the field of global mental health has focused primarily on increasing access to mental health care through this concept of task shifting, development of new interventions, training individuals like technicians of psychiatry, developing new models, which I'm sure people in this room are aware of. For example, where you train lay providers to try to address some issues, maybe developing AI chat bots, these different interventions, right? But there's actually been surprisingly little to no attention to strategies to improve the quality of the care that is currently provided by individuals like psychiatric technicians in primary care. And this is especially important because there's so few of these providers, and so often these individuals are trained and then posted to a very rural area where they don't have a lot of access to supervision. They don't have a great community for retraining and support. So often people can feel like they're working in isolation. The work that we're going to talk about today builds a bit off of this concept of a care cascade. And this concept of care cascades in global health has primarily come out of the field of HIV, where back in 2014, the United Nations committed to the 90-90-90 goals for HIV, which I'm sure a lot of individuals in this room are aware of, where they were trying to get 90% of all people living with HIV to know their HIV status, 90% of those people with HIV receiving antiretroviral therapy, and 90% of those people receiving therapy having viral suppression. So having basically improvement in their daily life and the course of their HIV illness because they're on medication. These goals have been historically and enormously important and impactful in HIV. Having targets that are reported every year, often down to provincial levels in countries, to track progress towards implementation for HIV, controlling the HIV epidemic, ending the HIV epidemic. But when we think about this more broadly in a public health approach, and we compare the HIV care cascade to, let's say, the schizophrenia care cascade, there is no information. There's no information on, for example, in Mozambique, what percentage of people in the community that have schizophrenia are diagnosed with schizophrenia. And maybe even less information on, of those diagnosed, how many are actually continually engaging in care, how many are retained on care, how many are having improvement in their daily life or their symptoms. And so that is what this work is about. This work is about trying to figure out how we can take the lessons from the HIV care cascade literature and work and apply it potentially to mental health to push forward more rapid progress in quality mental health care within primary care. I guess now I went back to challenges. So related to this, though, there's a challenge related to the gaps in global mental health implementation science literature. And then as we go forward through the talk, there's going to be QR codes in kind of the top right or bottom left. If you scan that, it'll take you either to the paper or the protocol or the information that we're talking about. So we did a systematic review a few years ago with a number of students here at UW on looking at the existing literature for depression, implementation science for depression in a global context. And what we found is that the vast majority of studies that exist for depression globally that are in the area of implementation science. So they should be focused on how can we implement known evidence-based interventions into primary care and how can we achieve public health impact. The majority have had primary aims to continue to test a clinical intervention. So this figure here shows that there's a research flow from starting out where you might test whether a new clinical intervention like a COVID vaccine is efficacious in like a laboratory setting. That would go to potentially testing real world effectiveness in trials with community members. Then if you know that the COVID vaccine is effective, your next goal is to get people to use it and to get it to impact population health. And that's actually been a major issue, right, in the United States, is that, and the world. But even in the United States, where there are resources and the COVID vaccine has been available, it was funded by the government, we have had relatively low uptake relative to other countries. So we have an issue in implementation. And so that's this T3. What are strategies to optimize the implementation of the clinical intervention? And then after that, how can we scale this up? And if something is already scaled up, how can we make a continuous improvement of that clinical intervention that's being provided? And you can see here, this percentage here suggests that 67% of published depression papers were still focused on testing a new clinical intervention. Only 5% were focused on scale up of depression interventions into routine care. And there were no published studies that were trying to improve depression care as it's already being delivered to populations in the community. And so there's huge gaps in the literature. And that's one area that we're hoping to contribute to through this work. Are we just doing questions at the end, or should we do questions throughout? What do you think? Yeah,
Up to you.
okay. Well, if you have a burning question, feel free to ask, and I hope you can monitor the chat. Okay, so the work we're going to talk about today is in Mozambique. I've been working in partnership with collaborators who unfortunately couldn't be here today, and the time zone for a 4 o'clock meeting would be very difficult. But we've been primarily working in the center of Mozambique with the mental health department and the Ministry of Health for about a decade. In Sofala and Manica provinces, and Beira City, which is right on the water. It's very beautiful. In Mozambique, approximately 12% of adults have HIV. It's a very high HIV prevalence country. It's has many barriers to the Human Development Index. It's rated quite low on the Human Development Index. Has a life expectancy of approximately 60, 500 GDP per capita, which is about less than $2 a day on average. And in the context we're working, about 10% of children died before age 5. So huge issues with public health, challenges within the public health system, as well as with general availability of resources. Okay, so what I'm going to talk about today is we originally started this work through funding from the National Institute of Mental Health from 2018 to 2021. And then now we're working on a larger project which will take this forward. So I'm going to talk about a bit about the results from that initial project and then move forward and talk a bit about what we're working on now. So as I was making this link between mental health and HIV, this work on the systems analysis and improvement approach, which I'll talk about in a second exactly what this approach is, originally came out of the field of HIV. And in 2013 to 2016, faculty in the Department of Global Health here got a grant to evaluate how we could potentially optimize and improve the HIV care cascade, primarily to prevent the transmission of HIV from mothers to children. So the PMTCT, the prevention of mother to child transmission of HIV care cascade. And this here is their example tool, which I'll talk about in a little bit more detail, but where you have pregnant women coming to their antenatal care visits. At the antenatal care visits, they should be tested for HIV. If they're HIV positive, then they should be enrolled in a different program to prevent the transmission of HIV to their child. Once their child is born, those children need to be tested for HIV and then enrolled in HIV treatment if they test positive. And this study was done in Mozambique, Kenya, and Cote d'Ivoire and showed significant effects on key care cascade outcomes through this overall SAIA approach. And the protocol is in the top right, and the results from those studies is in the bottom left. So the work that I'm going to talk about today was how can we take the lessons from this implementation strategy applied to HIV? How can we take that and adapt and pilot it for mental health? So we did a relatively, simple study where we just did a pre-post design. So in terms of whether we can say that this works yet, we're not there yet, but we were developing it and piloting it. And from September 2018 to August 2019, we had 6 months of pre-implementation data and then 6 months where we implemented the study and then did some mixed methods evaluation. The units where we implemented this was in 4 Ministry of Health mental health clinics with all patients who came in with any mental health problem. So that was a total of 810 patients with 3,234 visits during that time. And we did an analysis to evaluate whether this approach helped providers and helped individuals progress through this treatment cascade, which we'll talk a little bit more. So what is this SAIA thing? Systems Analysis and Improvement Approach. It's a 5-step approach that is similar to quality improvement, but not the same as traditional quality improvement. It starts out, what is new is that it starts out with what we call this cascade analysis, where we have a tool that, why this screen just turned off. Oh, man, there's too much going on here.
You can still see it through it.
Yeah, okay, anyways, sorry, my second screen turned off. Step 1 is this cascade analysis where you have a structured tool that helps providers evaluate how well they're doing at getting their patients through this mental health care cascade. You use that tool to identify areas in the cascade that are weakest, and you prioritize which area in the cascade you want to focus on for your potential improvement. There's process mapping, which is used to make sure that everyone in the health system working on mental health is on the same page with how the system is set up, and to help brainstorm potential areas for improvement. Step 3, you use the data from step 1 and the information from step 2 to create an implementation plan around what you actually want to do for your microintervention. You assess the change effect on your cascade, and then you repeat these analysis and improvement cycles approximately every month. And in addition to that, these are layered upon development of a facility level learning collaborative. And so bringing people from different areas in the health facility who might not be historically working in partnership with mental health in, the facility directors, potentially individuals involved in pharmacy, individuals involved with primary care, together to work on this as a team. Local clinical consultation, which is that there's an involvement of the Ministry of Health staff as part of these groups to potentially talk about issues around specifically clinical needs, and then facilitation in quality improvement. So this in the top right is our protocol for our new larger project, which has a lot more details if you're interested in reading that. But one of the things that we did in this table, which is a lot, but we mapped the individual elements of this implementation strategy, so SAIA mental health, to the barriers that those individual elements are supposed to overcome in the health system. And so if you're asking, for example, why do we have a cascade analysis tool as the first step in this implementation strategy? Well, it's because the providers do not have data on the performance of their system available to them. Providers in many mental health systems, many mental health systems globally, but especially in Mozambique, they're collecting a lot of data. Every time a patient comes in, they're writing down their name, they're writing down their complaint, they're doing screening, they're doing an evaluation, they're diagnosing, they're providing treatment, right? All of this stuff. And then that data is sent to the facility level, which is then sent to the district level and the provincial level. It's in a traditional reporting system, right? Of how many patients are being seen, all the stuff. But data go up, but they don't often come down, right? The data are not fed back to the provider so that the providers can use the data to change or to influence the way that they do their work. And so that's one of the areas that this work is trying to overcome, is the lack of data for prioritization. Lack of knowledge of problems, data only collected and reported, but there's not feedback, and potentially limited accountability. So if you're interested in looking a little bit more about the structure of the development of this intervention and the barriers that it addresses, check it out in the protocol. Okay, what does our care cascade look like? So in this work, in moving and adapting this work from HIV to mental health, we had to come up with indicators that are available within the mental health system. So data that is routinely collected by providers that we could use to populate a care cascade, meaning the steps that a mental health patient needs to go through to have successful treatment. We needed to be able to populate that cascade from data that are available. And so it creates a challenge in like how specific indicators could be, right? Like we couldn't develop an indicator on a mental health thing like some biomarker on their mental health status or something like that, like blood draw, a specific blood marker, because that's not routinely done as part of service, right? If there are real biomarkers for mental health, which we don't have many of them, but if there were. So so this cascade is kind of high level, right? So we have two separate cascades. You have a cascade where people come into care, so the diagnostic cascade, the intake cascade, and then people in mental health are seen routinely in a chronic care model where they're coming back, they're getting their side effects evaluated, they might have their medications changed, their treatments might change a little bit, over time, right? So in the diagnostic cascade, we have people in the community who have mental health problems. Some of those people are being diagnosed. Of those people who are diagnosed, people are being prescribed treatment. They're given a follow-up date to engage in care, and then they come back at some point. In the follow-up steps, we have people who are coming back for care. People need to come back for care within some sort of window. They're usually given a time that they're supposed to come back, a date that they're supposed to come back that represents something important for clinical care. They need to be adherent to their medication. So one thing to note that this work, for simplicity of the cascade, does not include psychological care. This is pharmacological care provided for mental health. Just because the care cascade for someone who's getting a psychological treatment might be different. And so that could be future work, is thinking about how to integrate multiple cascades across different types of treatment for mental health. And this is where mental health is really challenging. Someone with HIV, they have a standardized treatment regimen, whether, when they're diagnosed with HIV. Whereas mental health, someone with depression might have a different treatment guidelines than someone with schizophrenia, someone with epilepsy, someone with anxiety, right? There's very differentiated treatment algorithms. So for this work, for simplicity, we've tried to create a cascade that can apply to all diagnoses as long as someone is within psychiatric care for medication. So there's going to be a lot of individuals who were referred to the psychologist who won't be included here, just for the purposes of this initial work. Oh, and then our last, so people need to return on time and be adherent to their medication. And then in theory, the ultimate goal of all of this is function improvement in daily life, activities of daily living. Again, we couldn't do like a symptom measure because the symptom measure will be different for individuals with anxiety versus depression versus schizophrenia versus epilepsy versus other conditions, right? And so we did a general function improvement outcome. Questions? Online or in person? Okay, so just a little bit more detail into the steps of the SAIA approach. So step one is to describe this mental health care cascade in performance and identify priority areas of improvement using this cascade analysis. So on the right here is an example. You have new schizophrenia diagnoses. You have diagnoses where someone was prescribed a medication, because that's the intake for our current cascade, is psychiatric care. And then they're given a follow-up date to return to care. We then have a certain number of schizophrenia patients in care. We have a certain number who are supposed to come back for a follow-up visit during a certain time period, let's say a month. How many of those people come back? How many of those people come back on time? So plus or minus 5 days of their scheduled appointment. How many of those people come back on time and could have been adherent to the medication? Now, how do we measure adherence using routine data? We use a very general proxy, which is the number of pills dispensed from the pharmacy and the number of days, or the number of pills and the amount that they would have needed. Like, let's say they got 30 days of pills and when they came back. So it's a potential for them to be adherent. Of course, there's going to be people who, let's say they got 30 pills and they came back in 25 days. Well, they're going to maybe get more pills, so they could have been adherent. Doesn't necessarily mean they were. So that's what this marker is based on pill counts and when they came back to get a refill for their medication. There's other limitations to that. You know, we could say that someone could get medication at a private pharmacy, although for mental health care in Mozambique currently, there's not a lot of availability of mental health medications in private pharmacies or external sites. So returning for follow-up care and adherent, and then of those people, how many showed an improvement in their daily functioning? Okay, so this cascade analysis tool provides this global systems view for a provider, mental health provider in Mozambique, about how are they doing at providing these mental health services to their patients. And it helps identify which area in the care cascade are we losing the most patients? Which area in the care cascade are there potentially patient barriers? Are there health facility barriers? Are there provider barriers that are impacting on the quality of the care that we're able to provide? And this number on the right here is what we call, you know, it's like a prioritization number. This 9 here represents if we were to intervene on this step 6, the adherence step, and we were to make the adherence perfect, so we were to somehow eliminate any issues with patient adherence, how many additional patients would we have achieve the ultimate goal of our cascade of function improvement? So we would have, if here we have 15 patients who made it to adherence. We lost 12 patients who came on time. So we lost 12 patients in between step 5 and step 6. If step 6 was perfect, we would have an additional 9 patients making it to function improvement. Why is it 9 and not 12? Because we also lost some patients between adherence and function improvement. Not everyone who is adherent had improvement in function. And what this number does is it helps prioritize in a setting where there's limited resources, which there are limited resources in every setting, as we're all aware of, right? Where can we intervene to get the best bang for our buck in this quality improvement model? So here's some pictures of our initial training where we were working with psychiatric technicians and psychologists, because they're part of the overall team, to have people understand their own care cascade and what is the performance of their current system at baseline, to then use that to identify where they might want to work on quality improvement. Following cascade analysis, there's process mapping, which is a method for these teams to describe their health facilities' patients' care pathway as a team. And you might think that this is super easy or basic. Maybe you don't. Maybe you think this would be hard. I don't know. But this is extremely difficult. If you try to get a group of people who are all working in a health facility in different areas and different programs, humans love to, well, maybe we don't love, but we like to be siloed because we can easily understand our area, right? Even us, right? Like we understand our global health department, but someone else comes and they like ask us about, you know, health systems department or biostatistics. We'll be like, no, I'm not in that department. I don't know, right? I mean, you know, we'll kind of be like, I don't know, you have to talk to that department. It's the same thing in health facilities, right? And so this gets everyone on the same page of what are we actually trying to do? What does it actually look like? What are each of our jobs? What's our goal? All of those conversations, which sounds basic, but it doesn't happen. Plus, it builds morale, it builds a team atmosphere, and then you can use these maps to identify, okay, we have an issue with patient adherence. Where in this system do we think we could make a modification that could potentially positively impact patient adherence? So it helps brainstorming micro interventions and small changes that the team could test in this overall SAIA approach. And then steps 3 through 5 are built on continuous quality improvement. So this definition and creating a blueprint and a work plan, monitoring how you're doing over the course of that month, using specific indicators, specific metrics, and then repeating your analysis and improvement cycle by looking at the care cascade the next month and looking at your performance metrics the next month, as well as run charts or longer term charts of how you're doing in your care cascade over a longer period of time. So the idea of this is that this cycle, this 5-step cycle, occurs approximately monthly at the health facility level, including all of them: cascade analysis, revisiting your map, creating your blueprint, evaluating, repeating. Questions? Does that make sense? Okay. All right, let's talk a little bit about the results from this pilot study, and then a couple more things, and then we can just open it up for discussion. In the pilot study, in those 4 clinics, amongst about 3,000 patient visits, 800 patients, each month the clinics are identifying where they want to focus. The majority of the modifications targeted patient adherence. And so the majority of these cascade analysis tools suggested that the weakest spot in the care cascade was a loss of patients around patient adherence. And some examples: each clinic identified a different microintervention, and then might have applied a microintervention for a month or 2 and then shifted to a different one. They decide at some point whether they want to adopt the microintervention, adapt the microintervention and try it again the next month, or abandon the microintervention. So over time, the purpose of this is you're doing these cycles, they're repeating monthly, and you're slowly adopting new practices that then just become part of standard of care. And then you can move on to take on another barrier. So a barrier is that patients were returning late with poor adherence to their medication. The type of change was to potentially provide some additional buffer medication. This might sound basic too. I don't know necessarily how this is done in every country of the world, but there are standard protocols. So like a patient comes in with schizophrenia, they come into their first visit, they're prescribed a medication, and then they're marked for a follow-up consult, maybe 30, 60 days, come back. And then they're given 30 or 60 days of medication. And medications are not really available outside in like a standard, private clinic or something like that. Patients need to come back, they're evaluated, and then they're given additional medication. So if a patient comes back a few days late, their medication might have run out. Patients sometimes come back when their medication runs out. So it's time for my follow-up appointment. So thinking about different, more patient-centered, more flexible models around how you mark the follow-up dates, how much medication you give to the patients relative to the follow-up dates, etc., was some examples. Some other examples were encouraging a family or friend to participate in the consultations, integrating a psychologist to provide problem-solving therapy for targeted patients. So this concept of creating more of an integration within the kind of siloed worlds of the psychology and the psychiatry, right? Okay, so talk a little bit about the results. So we had 810 patients, 3,000 visits over the course of the time period. It was approximately balanced on gender identity. Average age of these patients was about 29. Significant number were homeless. The sample of those people who are receiving mental health care currently in Mozambique skews towards more severe mental illness. And this is relatively common in areas where mental health systems are more developing, because people with more severe illness are more likely to seek care versus someone with a common mental illness, right? Significant number reported suicidal ideation at their visit, and we had very high rates of HIV. Approximately 33% of people reported being HIV positive. Okay, the big reveal. This is the performance on that care cascade that I talked about at baseline. So I'm just going to focus on the follow-up visits, so the repeat visits of patients coming back to care. So of all follow-up visits, 45% of those visits, people came back to their appointment within 5 days on either side. So a 10-day window around their scheduled time. You combine that with people needing to come back in time to get their medication before it ran out, goes down to 14%. And then if you combine that with achieving function improvement, it goes down to 4%. This is similar to what we saw, for example, in that HIV care cascade figure, where even if you achieve decent coverage at each cascade step, if you multiply them together, the need for someone to be HIV tested and on medication, and then on medication and having viral suppression, you lose a lot of people over time, right? So following 6 months of our implementation, this was not a randomized trial. This was just a pre-post study. Tons of issues. There was a huge cyclone at the same time. There were, other issues in the health system that happened during the same time of the study. So this is not to say that this approach works. We're working on a larger study right now. But there was a change in the percent of patients returning on time and adherent, and the percent who were returning with function improvement after the intervention. But we are working on a longer current study to evaluate that more robustly. Here's a quote from one of our psychiatric technicians that I really like. Before SAIA, we were working very hard, but the cascade shows we're not getting results. So they're working really hard, but then all of a sudden, they start looking at these data, and it's like, we're not getting the results that we hope maybe to get. But now we're able to focus our energy through the prioritization, and we're making good progress. So right now, we are working on a larger study that started in 2021 and goes to 2026, where you're implementing this approach in 16 health facilities, so 8 intervention, 8 control. The health facilities are randomly allocated, and so the issues of so many other things happening, right? Worker strikes, lack of access to medication, stockouts of medications, economic problems, conflict, election-related conflict, all this stuff should hopefully be balanced, right, between the health facilities, although it's still a challenge. And the goal of this is to improve loss to follow-up, so people coming back for their appointments, visit adherence, medication adherence, and patient-level function improvement. And we're going to also evaluate the costs and potential cost effectiveness and look at barriers and facilitators to optimize the strategy. We're doing 2 years of this. That would be 24 of these monthly cycles. And then we'll do a 1-year maintenance phase where we're going to transition all of the implementation to the ministry and hope that it continues to at least function with some effectiveness, or we'll study how well it functions. Another thing we're doing, which is a little bit innovative and might not work, but that's part of innovation, I guess, is we are looking at the potential mechanisms by which this implementation strategy works or does not work. And so the concept is, we'll study whether the systems analysis and improvement approach, whether it, let's say, improves accountability, teamwork, understanding of the system performance and those different bottlenecks. So we can understand how this strategy improves teamwork over time. This is very hard to measure and very hard to do, which is part of the challenge. If you're imagining how can you measure teamwork on a monthly basis over 3 years. So that is it's a serious challenge. But we can also evaluate whether teamwork seems to be associated with changes in our mental health care cascade. And so we can talk about evaluating the left side and the right side of this figure. We can also look at moderators, so factors that might affect how that changes, as well as preconditions. So like people need to have stayed in their job during this time period, because otherwise it's hard to measure their changes over time. And the idea is we could see, okay, maybe teamwork seems to have a strong association with treatment cascade performance. So teamwork seems to be associated with patients being more adherent. But it looks like our SAIA strategy didn't influence teamwork in the way that we hope. And so then we might be able to optimize and improve our strategy itself to more focus on teamwork. Or vice versa. You know, maybe our strategy improved accountability, but it doesn't look like accountability is really strongly associated with changes in the actual patient outcomes. And so maybe we want to reformulate it to focus less on accountability because it's wasting people's time or something like that. You know, so there's different ways you can use these mechanistic models to optimize your implementation strategies. Okay, a couple more slides and then I'll be done. This is our current care cascade in the 16 Ministry of Health clinics, March through September of 2022. So clearly, you know, for example, like, you know, post-COVID and all that, there's so much going on in these health systems that you really need to do a randomized trial to try to eliminate a lot of those barriers or the things that are happening over time. But so you can see 66% of appointments were attended on time, 36% on time and adherent, and 11% on time, adherent, and function improvement at baseline. So this is before our SAIA study. And you can see that it has improved a bit compared to our pilot study, which happened, you know, a couple of years ago. A couple other things that we are working on. So this study was led by Sarah Gimbel, who's also who's faculty in nursing, actually, to specify what are the core elements of this SAIA thing, the systems analysis and improvement strategy. Because SAIA, we're talking about SAIA right here applied to mental health, but SAIA has been applied to HIV, as mentioned. It's been applied to opioid use disorder. It's been applied to juvenile justice, family planning, a lot of these different health care cascades to try to see how generalizable this type of approach might be. Cascade analysis, process mapping, and then the structured quality improvement. And this paper was specifying what are the core components of this approach and what are the components that might differ based on the different care cascades or different health conditions you might apply this approach to. There's also a website that talks a lot about all the different projects. It's SAIA-strategy.com. So if you're interested in checking out, maybe you're not, I mean, I guess most people here are probably interested in mental health or you just came because you're interested. But if you're interested in a different health condition, you can check out whether there's a SAIA project in the health area that you're interested, maybe get involved, or be another collaborator and see if maybe you have an idea to apply this to something totally different, which I think would be really interesting. There's also been work to see how we might be able to apply some of these elements of SAIA in isolation. So there's been work on how this cascade analysis tool and the cascade analysis concept can be applied alone for healthcare improvement, public health, around HIV and non-HIV settings. So this is great work done by Dr. Anjali Wagenaar, who's also faculty in the Department of Global Health. An area that I'm very interested in and hope to work on in the future, or maybe a smart person here or on Zoom will want to move this forward and with support or as part of a dissertation or as part of a grant, is thinking about how this work can be applied to suicide prevention. I mean, if you're talking about a care cascade that is not only urgent, but has huge potential, has huge challenges with patients flowing through multiple steps to get the care they need, suicide prevention is a very urgent and important one. Suicide rates have increased 30–40% in the United States across all racial ethnic groups in the last decade. And areas like Mozambique has the 6th highest suicide rate in the world, although there's been almost no research on suicide in Mozambique ever. And it has a gender-specific suicide rate that is like something probably like 5 to 6 times what the suicide rate is in the United States. So there's huge issues with suicide prevention in low and middle income countries, and specifically in sub-Saharan Africa. And it's an area that historically has been 100% ignored because of historical focus on infectious disease, really, I think. So that's an area of interest. And there's been great work by Emily Haraz out of Colombia to start pushing forward, taking a care cascade approach to suicide prevention. Okay, so in summary, SAIA is a promising strategy to potentially improve mental health care cascade performance in low resource settings with limited resources itself. Potentially particularly urgent given how poor the baseline care cascade performance is. We talk a lot about access to mental health care, training providers, but if the quality of the care that we're able to provide is low, then we also need to focus probably at least at both ends, or maybe more focus on quality to make sure a system is effective before we bring more patients in. It could be potentially an efficient strategy in resource limited settings, given it utilizes existing resources. The field of global mental health urgently needs more studies focused on improving quality of routine mental health care delivery. We have enough clinical interventions. We have so many clinical interventions for mental health, from medications to, psychotherapy provided by lay providers to mid-level providers to, we have so many clinical interventions, but they're still not getting out to people. And even those that are getting out to people then may be not of optimal quality. So we should really be focusing on that later stages in implementation on that graph, the graphic that I showed, rather than testing more clinical interventions. And then the SAIA implementation strategy seems to be feasible, and hopefully some interesting data to be generated in the coming few years. So I want to thank primarily our team in Mozambique, the Mozambican Ministry of Health, Vasco Kumbi, Alberto Moanido, Isias Romero, the entire CSM team in Mozambique, and then Kenny Scher, Sarah Gimbel, Steve Gloyd, who helped to generate the initial evidence on SAIA, the mental health providers, mental health patients, all other UW faculty, staff, and students. And then this work has been funded by the National Institute of Mental Health through the NIH, who have had a very big push to be more interested in global mental health, because work like this has very strong potential applications both in Mozambique, in many different countries of the world, and in the United States. We have huge gaps in our mental health care cascade as well. So thank you, and yeah, we can have some questions. Zoom or in person?
Thank you so much, Brad, for this wonderful presentation. I really learned a lot again from you. One question I had was, thank you for what stuck with me was the team has to do this 5-step cycle each month. So what were their reactions or experiences throughout the intervention period, especially towards the end of the period? Month 6, when they have to do the cycle, is there any adaptation to the core set of steps that they need to do?
Yeah, so the question was, what's been the experience in implementing this process each month over the longer period? So we are 1 year into our current project, where we're working in 8 health facilities as well. So they've been implementing it for a year. And I mean, I don't want to sound like I'm some sort of like SAIA convert or anything, because there's huge challenges, and we'll see whether this has positive impacts or not. because it's hard to overcome so many barriers, you know, in a system, even if people like it. But people, and in Mozambique, the context is perfect for something like this, because for most people, the act of coming to the health facility and being like, your work is valued, your work is important, mental health work is important. We want, you know, we want to partner with you. The ministry wants to invest in this. People are like there's never like, they see daily all the resources being pushed into HIV, and it's like all through PEPFAR, and PEPFAR is an important program. HIV care is important, but people feel marginalized. And so my experience has been that the idea of investing in the mental health system is just so welcome. People are really excited to feel like their work is valued, their data is valued, the hard work they're doing is valued. They can see the results they're having through the data each month and the next month, the next month. So they're very excited to get the cascade each month. They're like, oh, how did we do? You know, how is it looking? Kind of thing, which, you know, I mean, hopefully it's a positive, not a negative thing, right? And it's all about the culture. So whether something like this would work in other contexts where maybe mental health is overburdened. So in the US, we've been talking a little bit about SAIA, and people are like, there's no time. People are overwhelmed. Mental health care is overwhelmed. There's way too many patients. People don't have time to do anything. So the concept that you could then bring this into our context might be really challenging. Whereas in the Mozambican context, often the providers don't have that many patients. Like they could use more patients. We need to focus more maybe on demand creation to get more patients into the system. So people have a little bit of time. They're not so overburdened relative to, of course, there's this burden in the community, but in terms of how many people are coming for consults, it might be a little bit lower. So, and then in terms of the actual process itself, the one part that people don't necessarily do every month is the process map. So they create this map on this big, you know, often like a big sheet. They put it on their wall, and they might talk about it a little bit, but like they're not gonna spend, you know, 4 hours redrawing the whole map every month, because not a lot has changed in particular, right? And so that's one step that, you know, could potentially be rethought and reconfigured of like how this fits into the monthly cycles. Yeah. Did that answer your question? Yeah, cool. Yeah, in the back.
What were some ways that you measured the like functional improvements in their mental health? Like, was it an interview format, or how did you measure that?
So the question is, how do we measure the function improvement? Sorry. It's like not so used to like talking so much. So it's like, no, I'm good. I got water. Thank you. Yeah, I should have mentioned it. Sorry, there's so many things, but we use the WHO's disability assessment schedule, the HUDAS, it's called 2.0. It's a 12-item structured survey that the WHO developed cross-culturally to be, in theory, cross-culturally valid to examine function. How culturally valid it is, I think there's significant questions. I think if you look at the countries it was developed in, I'm unsure that it maybe included one African country, but obviously Africa is not all the same. It's a very much not so. But that's a huge challenge, right? So in order to measure the function improvement, we need a tool that can be implemented at every visit. And so what's a tool that can be valid and effective, but is not too much provider burden and can hopefully be helpful for them in their clinical exam? And so that's another challenge. If you take this to another environment, what is a way that you can measure improvement that providers are going to really buy into? But it's the HUDAS is what we're using. Yeah. In the back, yeah.
So mine is a comment and thank you for very good presentation. I've participated in improvement processes in the HIV program in Kenya. But I think why I like SAIA more is because looking at, sometimes when you're doing improvement, you look at the challenges you think are the challenges, but this helps you using a systematic way, then it helps you pick some of those things, more small things that you don't think are the challenge. And once you work to improve them, then it gives you the bigger picture of what you're lacking. So it's something I'm very, very interested in to follow through and to see how I can also use it in other settings.
Thanks. Yeah, I mean, the comment was that SAIA seems to be more structured than other QI approaches. And, QI is an amazing innovation, and the Institute for Healthcare Improvement, IHI, kind of came out with this breakthrough series and was, has been very focused on QI. There's a lot of work on QI. A lot of people know about QI. But one of the biggest weaknesses, and if you look at systematic reviews about the effectiveness of QI, is that it's not always been very structured. So there's always this balance between structure and flexibility, right? And so SAIA is trying to thread the needle where it's more structured, it's got a very specific process, and it can be slightly adapted to different contexts, different health systems, different health illness areas, but it's quite structured versus a general open-ended QI process. So
I just wanted to bring up a couple questions from online. Cam was asking, looking at the social determinants of health, what was the most common social determinants of health you saw when running your research? And then also, is stepped care similar to SAIA?
So yeah, it's stepped care is usually focused on clinical intervention systems modifications, where you will change to say, a patient comes in and is seen by a lower level provider, maybe even a lay person in the community screened, and then if they're positive, they go to a higher level care, and then if that higher level care doesn't work, then they get referred to a higher level care. So it's stepping up patients as severity increases, or as maybe effectiveness of their treatment is not, their treatment's not being effective. SAIA could lead to providers choosing to change the structure of their team and change the way in which patients are referred. So it could result in changes, but it's not a structured, it's not saying that it has to be a certain system where it has to be stepped care. So stepped care is one model by which patients are referred within a system. And SAIA is, I guess, agnostic to that. The providers themselves would choose what is the best model for patient treatment. That makes sense for their context. So that then they could use stepped care, but it's not the same. Social determinants of health is like, a huge, complicated area that is unfortunately neglected in global mental health. I don't hope I'm not offending anyone. But given our work is dominated by the biomedical model, primarily dominated by clinicians, most global mental health work has been testing clinical interventions in a clinical setting. SAIA-MH is a very clinical funder. And NIH tends to really like clinical studies, clinical trials, randomized trials. So there's been limited work on how we can address social determinants of mental health and how can we do evidence-based interventions to address social determinants of mental health. Huge area that is a gap, huge area that should be another focus for the next 20 years, because there was a Lancet Commission on Global Mental Health a couple of years ago. Big thing, tons of papers, tons of information. The one thing in there didn't scare me, but one thing in there really stood out to me, and it was treatment availability for mental health has increased dramatically over, I don't remember what it was, decades or something. So went from very little availability of mental health treatment to like relative availability on average, almost no one's getting treated for mental health. And now it's, 20, 30, 40, 50%, depending on where you are, which country you're in. Maybe some countries might be up to 60, 70%. But the incidence, the incidence and prevalence. So the new mental health cases and the existing mental health cases have only increased. And so this concept, that I think a lot of people are coming at this kind of from more of the infectious disease mindset, where with HIV, we can treat our way out of an epidemic. The whole point is treatment as prevention. We can't do that in mental health. We're not going to treat our way out of mental health as being a core component. And we cannot live in a society where we accept 30% of our society to have a mental health problem. And clearly, the way that our society is structured, including society in Mozambique, including equity, social justice, everything we talk about in global health is related to all of that, poverty, everything, right? So I can't, Cam, I appreciate your question, but it's more of a, hopefully my answer wasn't too negative. But yeah, we need a lot more work on social determinants for sure.
I have one more question first. Curious about like the what you saw as your study progressed, and maybe in the current study, like what you see as the sort of incremental change, since it's there's a feedback loop that's happening, and there's continuous change over time. Do things ever slide? Are some of the decisions that are made like affect the sort of outcomes negatively in a way that's clear enough to be like, oh yeah, that wasn't the right move, like that actually resulted in patients coming in with less sort of adherence and improvement. Yeah, just curious about what you saw like in the incremental build versus pre-post.
Yeah, I mean, hopefully in another year, hopefully if people aren't sick of hearing about this project, we'll have the results from our largest study and we'll be able to really get into that. As of now, we're not looking at the data from an analysis perspective because it's a randomized trial, so we're waiting to the end. But what I can say is, I think we're in a unique environment where there's so many opportunities for improvement because the resources are so few that I think that it's hard to see a negative impact because the resources are so few. People are like, so I think the fact that there's work being done to support the mental health program, and this is where part of our study, we are providing the same level of support in the control facilities. They're just not getting SAIA. So we're visiting them on the same frequency. They also attended a training. They're getting the same basic package of resources, including things to measure blood pressure, for example, because, stuff like that. So all of those elements are going to be included in the control, but I think we're going to see improvement, I guess, because the amount of previous work is so little and people are really appreciative of any support. For example, the Ministry of Health is supposed to be visiting these health facilities on a routine basis for supervision. It doesn't happen. They don't have any fuel. They don't have a car, right? So the most basic things that you would expect to potentially be part of the health system are often not functioning. And as part of this project, we are visiting the health facilities every month on a very regular basis. So they're getting that support, right? Which might includes support other than just the information, just SAIA.
You have another question online about how you're measuring teamwork. I know you said that was difficult. And also curious how you see CFIR adding to the SAIA structure. And
yeah. Thanks, Ashley, for your very hard questions. Okay, so when we got this study funded, the idea, right, is okay, we're going to try to measure, let's say, teamwork. There's no validated tool for measuring teamwork in the Mozambican context, right? And so we spent a lot of time trying to find all these different validated tools. There are tools that exist, let's say, for teamwork that have primarily come out of hiring, US or maybe Europe settings. And you read them and they don't make sense. They have a lot of items that don't really make sense for the context we were working. So I hope it's not too offensive to Ashley or others that basically we created our own tool to measure most of these factors that make sense in our context and that is not overburdensome. Because if you try to measure all of those outcomes we put on there with like some validated tool from the US and then you translate it to Portuguese, it's not going to make sense. And in addition, it would be like a 400 question tool that you'd be applying every month. So we took the lessons that as we could from the existing literature and adapted and created our own simplified tool to get an idea of teamwork. But it's a huge limitation of the work. And so hopefully we can find some signal in the mechanistic analyses that can help push that work forward in the future, but it's certainly not going to be some end-all be-all analysis of the potential mechanisms. And CFR, we're going to use, we have other stuff that I didn't include in this. For example, we're going to segment the clinics into high and low performers, and then we're going to apply the consolidated framework for implementation research to try to understand the drivers of high and low performers in SAIA. As well as we're going to look at high and low mechanism performers. So individuals that showed like a huge change in their mechanistic mechanisms, they will be then interviewed and compared to people who didn't show as big changes in their mechanistic outcomes to examine barriers, facilitators, and potential ways that the intervention could be improved and trying to explain the quantitative results, basically.
Great, well, we are at 4 minutes and 16 seconds, or 64 hours. Anyway, it's 4:16. That's what I'm trying to say. And we said we're gonna have a reception, so we should do that. Thank you so much, Brad.
Thank you, everyone. Thanks everyone on Zoom. Thanks for the questions. Have a good rest of your day.